hindbrain segment. If you look at the brain stem from the front, you see big bulbous pons, and you see the peduncles going up, and the interproductor pops up there, turning the front line across like so, and then the medulla comes down, narrows into the spinal cord, something like that. A basilar groove, dividing the pons in half, a midline, dividing the medulla in half. Groove along here, separating the pyramidal tracts as they come down across. Making an upside down pyramid. The base is here, and the point of the apex is down below, and that's essentially the pyramidal part of the pyramidal tract, the external gross landmark. Now, off to the side here, we have bulges in the inferior olive, and these structures that your basis pontus, and the cerebral peduncles, represent major suprasegmental structures that obscure the basic segmental apparatus behind. And so we have a choice of dissecting these away and leaving the reticular formation with tegmentum behind, or of accepting these as landmarks, gross landmarks for the moment, and make our cross-sections as we desire. So if we look at the cross-section, say through the middle of the posterior hindbrain, we find something that looks like this. A midline, the sulcus limitans, and a big bulge, another big bulge, and the pyramidal tract, and off the other side. And these bulges are for the inferior olive and the pyramidal tract. And if we just use those for the moment as gross landmarks, you won't see them any other place in this pattern except here in a cross-section of the medulla. The segmental portions are hidden back in the tegmentum. By analogy with the pons, we could just cut across here and have bases of the medulla and tegmentum representing the reticular formation largely beneath the floor of the fourth ventricle. And we will look for the segmental structures in this tegmental region. Now we will find this exactly the same as we saw in the spinal cord segments, with one little exception. And that is that if we look at this in the embryonic stage, instead of having, say, as a spinal cord segment with the sulcus limitans and the floor plate, we will find that this roof plate here widens. And so what was dorsal now becomes lateral. And so this will look something like so as we come to take the midline here, the sulcus limitans, and out and up as the roof plate, coming around here, sulcus limitans, and out the roof plate, and around like so, And here's the roof plate over here, markedly expanded, so that the fourth ventricle is a big structure in contrast to the little spinal canal. But the sulcus limitans has essentially the same relationship between motor and association plates. And we would expect to find motor and association plates separated by sulcus limitans, but medial to lateral rather than ventral dorsal. And so we will look for the motor plate containing medial cells, large anterior horn cells that send their axons forward as the 12th cranial nerve to the tongue. Lateral cells that have a slightly curious force in that the axon goes back before it turns around and comes out laterally. And depending on what level we're at in our cross-section, this will be the 9th or 10th, or down in the spinal cord, the 11th cranial nerve nucleus. And because of this pattern of the axons going back and around, it's known as the ambiguous nucleus. For ventral 9 and 10, ventral glossopharyngeal or vagus nucleus. It's one column of cells that runs from above down into the spinal cord as a long column of cells. In any one cross-section you might see a half a dozen or so at most. Now the dorsolateral component of the segment is going to be where in relation to the sulcus limitans?
Or lateral.
Lateral, sir. Well, we have three possibilities: medial, lateral, and right at it. One vote for lateral. Any other votes? Medial. Any votes for right at it? Sure.
What do you mean?
What are you asking about?
In the spinal cord segments we've talked about, the motor plate is separated from the association plate by the sulcus limitans. And in the motor plate we have three components: medial, lateral, dorsolateral. And so where is the dorsolateral component, the autonomic component of the motor plate going to be? And this distorted segment, medial or lateral? Change your vote to medial. It ought to be the motor plate, or something like that. Association plate ought to be the lateral tube. Dorsal tube here, the lateral tube here. So we're going to be looking for association nuclei out here. But we're still going to be looking for motor nuclei. If I were to draw the spinal cord into this axis, so this is dorsal ventral, it might be more obvious that sulcus limitans has kept the motor plate ventral. Okay? And so here we have neurons that are going to be preganglionics to postganglionics, the 9th and the 10th cranial nerves, also known as the dorsal motor nucleus of 9 or 10, in contrast to the ventral motor nucleus of 9. Okay, makes sense? Got in the right general position? The motor component of 9 is, from a clinical point of view, relatively insignificant. The voluntary part goes out to a small muscle, stylopharyngeus, which if paralyzed is clinically insignificant. It's one of the pharyngeal muscles. The autonomic component of 9 is relatively insignificant clinically, going out to the otic ganglion and then to the parotid gland, and one can do without its secretion because you have other salivary glands. The 10th motor components, however, are important, both voluntary and autonomic. The voluntary motor activities of 10 relate to other muscles of the pharynx, larynx, including the constrictors and tensors of the vocal cords, constrictors of the larynx and tensors of the vocal cords. And the autonomic component going out is preganglionics, postganglionics, the heart, lungs, GI tract. And those we'll come back to momentarily in relation to rather important segmental and intersegmental reflexes involved in control of heart, lungs, and GI functions. The 11th cranial nerve being a spinal nerve, we'll just put it here for completeness, which goes to the trapezius and sternocleidomastoid muscles, neck muscles, rather appropriate for cervical spinal segmental origins. But it's this piece of the ambiguous nucleus of the ventral motor voluntary complex of 9, 10, and 11, making up this long column through the posterior hindbrain and upper cervical segments that I call lateral, which you'll recall is different from the extremity-related lateral masses of those have ventral roots. The ambiguous has almost dorsal root location of the spinal cord. So you just have to remember there's a slight distortion, a slight non-synonymity of the use of my use of the latter. So any problems on motor plate of the posterior hindbrain segment? I'm sure you all know what happens if you cut the 12th cranial nerve on one side. The muscle on that side is paralyzed, of course, and in time will atrophy, so it shrinks. The midline of the tongue then at rest, or the mouth, moves towards the atrophic side. And as you ask the patient to protrude the tongue deviates to the paralyzed side because these two muscles are no longer opposing each other, and the atrophic one allows the normal one to deviate to the side of the paralyzed path. When we get to the functions of 9, I've already said it's clinically insignificant. Of 10, there are major voluntary components. Pharyngeal muscles that relate to the back of the mouth when one irritates or forces those muscles to contract. You can see them. The soft palate will elevate as the palatal muscles also contract. And so when you look in the back of the mouth, and we call it this segment that's identified with the mouth, essentially all the functions of the mouth open relate to this segment. You'll see the uvula hanging there. The way it hangs is totally irrelevant. It may not hang in the midline at all, maybe it's placed to one side, but it's the muscles on either side that cause the muscleless uvula to rise. And if one side is paralyzed, obviously that can't rise, and the other side doesn't, so the uvula midline shifts to the side of the good muscle. Laryngeal constrictors, very important in what function?
Swallow.
Swallow. It would be nice to constrict them so you don't swallow that the wrong way, yes. But how do you test it for the patient's point of view? You ask the
Pressure. Tongue pressure, reach in the back and touch it. For cough reflex, gag reflex.
Okay, that's testing more pharyngeal muscles, but how about the constrictor of the larynx? What can't the patient do if he doesn't have a constrictor function? Not quite. You can't close off the larynx and build up thoracic pressure to cough. You build up that pressure and then suddenly release it and cough. The patient who can't constrict that set of constrictor muscles can't cough. The tensors of the vocal cords do what? They tense the vocal cords, of course. But what does that have to do with anything? Speech. And what component of speech?
You can't see.
Oh, I think you can't tense the vocal cords. You can't get any pitch or volume. column of air that goes past the vocal cords is set into motion, and you bite off the phrases, the syllables, the consonants, vowels, with your tongue, lips, teeth, and they resonate through your sinuses, so the actual speech components, the language part, relates to mouth functions and shaping the sounds. But the ability to sing high or low notes, or to have soft or loud sounds, is largely a function of the potentials of vocal cords. While we're on this related piece, how about the sternocleidomastoid and trapezius muscles? What do they do? How would you test them? One of my old chief consultants at Walter Reed, Walter Freeman, had an 11th nerve palsy, traumatic induced, I understand. And he delighted in having the students, second year physical examination type, or even better, neurology residents, examine him. And almost invariably they failed, because they forgot one little thing. He could turn his head, shrug his shoulders, because he had other muscles than the sternocleidomastoid trapezius. You have to feel the sternocleidomastoid contract. Of course, he had nothing. Completely atrophic. And so he didn't palpate the muscle by asking him to turn his head. He failed that piece of the exam. He was delighted. I can just say this to start with. He delighted in having a hysteric patient who couldn't feel anything and stick a pin all the way through his wrist or something. They should look at his needle going through. Totally oblivious to it. He delighted in doing transorbital leucotomies with an ice pick. An ordinary wooden-handled ice pick, American Ice Company on it. Hammer it through, step back and take a photograph of the angle of the ice pick. I use a light character. But he was something that one learned to appreciate, because if you could get Walter to say something about a patient, the retiring board accepted. So all of our patients were, Walter Reed in those days, was the end of the road, who had to be separated, retired. We sent them all by Walter. And he would come up with the diagnosis and the prognosis, and the retiring board accepted. Out he went. So he was the authority in my day. And I dare say you will learn that in these consultants too. Okay, enough digression on that. We come now to the sensory plate of the posterior hindfoot. And where is the sensory plate going to be? Outside. Is that what you said, Mike? Sensory plate is not part of neural tube. It's part of neural crest origin. So the sensory plate's over in here on the spinal segments. And so it's going to be out here. As jugular and nodos and petrous. Ganglia, in the jugular canal. I forgot to tell you, I guess, that these nerves are exiting through the jugular foramen, which in effect is a jugular canal. Has to have an out exit through the skull. And so within this jugular canal lie these 4 ganglia, 2 for each of the 9th and 10th cranial nerves. And they contain small cells, small cells of the 10th, that go out to supply 3 nerve nets, of the behind the ear and in the back of the mouth. Larynx, so on. The central dorsal root equivalent comes in with the motor fibers, mixed nerve, and they enter into a tract that we mentioned briefly yesterday, where, like all nice sensory neurons, they branch caudally, right angles to the board, and this tract containing a large number of other fibers coming from the trigeminal nerve with its small fibers, first, second, and third division, coming in through the anterior hindbrain, branching rostrocaudally, a long caudal branch coming down even into C1-2 as the descending or spinal tract trigeminal. And so these sensory fibers of 9 and 10 come in and join these. I could have had the motor and sensory plate when I was off.
You say again, what's the features in the nodules?
These are ganglia, dorsal root ganglia equivalents, cell bodies, T-shaped neurons, just like spinal or trigeminal fellows. We never see them because we cut the nerves proximal, central, leaving the ganglia back in the canal. It's not an easy dissection, but they're there, and the sensory plate is essentially where it ought to be, namely out in the periphery. These, of course, now are going to send secondary collaterals. The nucleus lies just deep to it, which will be the association plate nucleus for the trigeminal. The nucleus of the descending tract, or spinal nucleus of trigeminal. And how many components does it have? 3. And they are well, how are we early in the morning for the 3 association plate for pain temperature. Marginal, gelatinosa, proteus. Same basic pattern, same polysynaptic chain of progressive connections for trigeminal and all other pain-related reflexes in the head. As I did not say yesterday, this pattern holds only for the caudal thirds of the nucleus. The rostral two-thirds does not have the same organization and presumably functions in a somewhat different way. So we don't know what the rostral two-thirds of this nucleus association plate for the trigeminal and other pain temperature systems is doing. But the caudal thirds rather clearly is behaving just like a spinal system. Small fibers. Large fibers. We don't know much about large fibers in this segment. Probably the only ones that are present are in relation to the 11th cranial nerve and stratamastoid trapezius muscle. And they probably have their cell bodies in spinal ganglia that somehow anastomose with the 11th in the periphery. And even that I don't know. So it's a somewhat reduced sensory plate. Not very many large fibers. But we do have medium-sized fibers. These come in to the 9th and 10th. Cranial nerves, along with the others, parallel to the motor ones going out. Branch at right angles to the cord, rostral, caudal, primary divisions. Just lateral, or in the classical spinal cord orientation, dorsal, to the sulcus limitarus. And give off secondary collaterals to a peculiarly placed nucleus that surrounds the tract. So that the tract itself stands out all by itself, being myelinated versus white matter versus gray matter. So even with H&E, you can see a difference in intensity of pink. If you do it with a myelin sheath stain, you will see this solitary tract. Nucleus around it, pretty obviously in any section you make through the segment. This nucleus turns out to be a very important one in terms of making connections to a particular formation in the tegmentum between the other motor nuclei. And this particular formation turns out to be very important for functions of heart, lungs, and GI tract. So our next step will be to sort of analyze the afferents through 9th and 10th cranial nerves from these three major peripheral sources and their connections through solitary tract, synapses on solitary nucleus, reticular formation, and appropriate reflexes established. So let's consider afferents that come in relation to the heart, blood vessels. Most of whose afferents come in through the 9th cranial nerve. We have, just schematically, we have a carotid bifurcation, some swellings. We have a carotid sinus. And the afferents in through the 9th nerve, cranial nerve, medium-sized cells, and the jugular petrous ganglia, entering into, and now I better draw my segment here. Orientation, let's have a midline. And that means outside here we ought to have some inferior olive and primal tract and spinal cord coming down. Inferior olive, primal tract coming down. Drawing the pons up here. And so here we have the 9th nerve coming in, and ending in the solitary tract, the primary branches, rostral and caudal, secondary collaterals, the nucleus around it, and connections from the nucleus to dorsomotor vagus, put that in. Dorsomotor vagus is going to be just medial to this. Autonomic cell bodies, which come out here through the 10th cranial nerve, down to the heart, to inhibit the AV node, I guess it is, and this association plate element that went to reticular formation and to dorsomotor vagus, establishes essentially an intrasegmental reflex that in response to rising blood pressure, dilatation of the carotid sinus, through the 9th nerve, sends out inhibitory messages to the heart to slow the heart rate. So it's an intrasegmental reflex that is not quite appropriate, related to the same system, but for rising pressure it slows the rate. It doesn't appropriately drop the blood pressure back. That component, the appropriate component, becomes quite an intersegmental response down in the spinal cord, where we have the thoracic have postganglionics by the blood vessels, and the reticulospinal connections inhibiting sympathetic preganglionics. So in response to an increase in blood pressure, we have an inhibition of vascular tone and a drop in blood pressure. So that is the appropriate response to maintain blood pressure constant. The afferents are essentially ninth nerve, and the efferents either 10th or thoracic, parasympathetic or sympathetic to heart or peripheral blood vessels. So that's one of the vital reflexes related to this segment. Any questions on that one? The second one, and very similar to it, is related to the gut, GI tract. Here the afferents are largely 10th. Input to the solitary tract. They're similar. Primary collaterals, rostrocaudal, secondary collaterals to the nucleus around it. Connections to the parasympathetic, dorsal motor vagus, and to the reticular formation, and down to the sympathetic preganglionics. This time the output of the vagus coming down, the preganglionics, postganglionics, and of the sympathetic preganglionics, postganglionics. Here we want to get to the pylorus. And here we want to get to the cardia, fundus of the stomach. And so when we have something irritating in the gut, vagus impulses come in through solitary tract, the nucleus, to reticular formation and dorsal motor vagus to go down and close off the pylorus. Go down to the spinal segments to open up the cardia, and also to anterior cells of the chest and belly. And so one empties this bag of stomach contents by vomiting. And so a small part of this is what you see when you irritate the back of the pharynx, your tongue blade, and the patient gags. And if you're unfortunate, the patient vomits. But one's just a smaller part of the other. So any questions about this part of the system? There is another component to the vomiting reflex. And that relates to a region of the wall of the floor and caudal wall of the fourth ventricle, the area postrema. Which is one of the half dozen or so places in the central nervous system that has a poor blood-brain barrier, which, if given enough time and enough toxic dye or whatever, will accumulate. So in the old days, trypan blue was the classical dye that would bind to albumin, of course, in blood, and stay in all tissues except the brain, spinal cord, or the nerves. So these would stand out as non-blue, except for little tiny spots, of which the pineal is one, and the subcommissural organ, and the supraoptic nucleus, posterior pituitary. The area postrema is the moment the one I focus on. So these are somewhat permeable blood vessels, and allow somewhat more than the usual oxygen glucose transport to the rest of the brain. And so we have centrally acting emetics. Classical apomorphine, but the toxins of anemia, toxemia pregnancy, metabolic, things like that. The emitter here, presumably in access, presumably through nervous connections, to the same region of the reticular formation and evoke vomiting. So one can experimentally dissociate peripheral acting emetics from centrally acting emetics by destroying the solitary tract nucleus or by destroying the area postrema. And one of the more adventuresome neurosurgeons of a generation ago, Lindstrom, who was for a while married to Ingrid Bergman, who for this generation, I guess, is known Casablanca. But anyway, her husband was a neurosurgeon in Pittsburgh and had some patients with prolonged vomiting, intractable. And I'm not sure who is the more adventuresome. I've always suspected the patients were braver than he was, to have someone go in needleless region. Most neurosurgeons, I like to stay away from it. They might. The floor of the fourth ventricle is sort of a ticklish region. But anyway, he had 95 patients. They burned out the area postrema and stopped their intractable, metabolic, toxic vomiting. I haven't heard of it being performed since, but there it is. And so then we come at last. Any questions about this component? If not, we now come to the respiratory system. Range signal. Down the back. Your olive. Olive coming down. Spinal cord. The palm goes here. So push your vertebrae. Afferents from the respiratory system, alveoli of the lungs, medium-sized units, coming into the 10th cranial nerve, ending in solitary tract, rostropodal primary and secondary collaterals to the nucleus. Second order connections from the nucleus to reticular formation. Next order elements from reticular formation downstream to C345, I guess it is. All right. 1, 2, 3. Make a phrenic nerve. And a diaphragm. And lower muscles down in here to thoracic intercostal muscle. And so the reticulospinal fibers come down ending on these elements. And one has the basis for regular rhythmic respirations, at least in the cat. One does not need more rostral nervous system. In the human, it doesn't seem to be quite that simple. But we seem to need some more stuff up in the pons, reticular formation. But anyway, with this foundation, we have afferents coming in from the dilating lungs as we are inhaling through solitary tract and nucleus to inhibit the motor neurons of the diaphragm. And so we stop inhaling, passively exhale. And if we don't have Undine's curse, we won't stop when we stop exhaling. We will recycle. If we don't have enough stimulus, building up CO2 in particular, we will not cycle. So that there is a continuous tonic stimulation of reticular formation for inhaling, contraction of the diaphragm, expanding the chest and lungs, and a cyclic inhibition that increases as our chest expands. I'll be like that. I cut it off. And so that's the basis of the Herring-Breuer reflex. If we cut the vagus nerves, we eliminate that inhibition. And so we have a greater volume and a slower rate as the lungs expand more or it cuts off. If we increase CO2 concentration, we increase the rate by driving the inhaling side faster than the inhibition can cut it off. So we have these two major ways of manipulating Herring-Breuer reflex. I haven't given you the whole story by any means. One small piece of it, though, relates to a bilateral supply to the phrenic nucleus, which can be demonstrated in the so-called Porter phenomenon. Where if one makes a hemisection of the spinal cord, let's do this right now, hemisect the spinal cord, the phrenic nucleus and nerve and diaphragm on that side are paralyzed. If we cut the phrenic nerve, the same thing happens. If we do the operation in the right sequence, namely cut the spinal cord on one side, paralyze that side's diaphragm, and then cut the phrenic nerve on the other side. Both sides are paralyzed for a while, which of course can't last very long, but the side below the cut presumably receiving some bilateral supply from the other side, now recovers. And this seems to depend upon the paralysis. First, following the hemisection, and second, following the opposite nerve section or paralysis. From that kind of study. Of building up of CO2 and an increasing drive of the respiratory center, particular formation, to get more impulses past that hemisected cord to re-stimulate the first paralyzed diaphragm. So if there's a quantitative relationship here that can be seen also in bilateral chordotomy patients, cervical chordotomy, where the goal is to relieve pain from the ascending spinothalamic tracts. They're running rather laterally, sparing the particular spinal tracts that are running rather medially. But every so often, one runs into a patient who stops breathing when he goes to sleep. And that, of course, can be embarrassing. He doesn't wake up. And was named Undine's curse because of what? What's the whole story of Undine?
The Hera's curse on
What, Undine was who?
what his relationship with Hera.
Undine was the nymph, the girl, the fairy. And it was her father who cursed any lover who would lose all of his autonomic functions. And of course, Undine herself, who cursed her lover. But this is one of the autonomic dysfunctions that would be fatal if the patient doesn't wake up. Unfortunately, in the bilateral chordotomy patients, usually transient, and they usually recover after a week or two. It's rather embarrassing having to wait to breathe. But I think it illustrates the fact that there are some diffuse bilateral descending tracts that can be quantitatively interfered with. Probably not so much by the direct chordotomy lesion itself, but by some edema that transiently occurs and enlarges the lesion and then worsens. That illustrates, I think, this reflex in an interesting way. So, any questions? To summarize briefly, we've got the same kind of neural tube, except it opens up laterally. So the ventral dorsal relationship becomes medial lateral. So the Slimitans, though, still divide the motor plate, association plate. The centric plate is still outside. The motor plate still has three components: two voluntary, medial and ventral lateral, and an autonomic, parasympathetic, preganglionic, dorsolateral. The centric plate has two of the three major components: small fibers related to the trigeminal, medium fibers related to the solitary tract, and therefore two association plate elements related to the trigeminal nucleus and the nucleus in the solitary tract. The major functions of this segment can be visualized by looking in the mouth and considering the medulla as a center of vital centers, a region of vital centers related to heart, lungs, and GI tract. And with these three major intra and inter-segmental reflexes for control of those three major functions. So, has everybody gotten a handout? Some came late, almost certainly didn't. So we've got some of these, which are sort of a printed up version, short